I think we might just start. So thank you everyone for coming, first of all. This is the Younger Fellows Symposium, and it's really a beginner's guide to presbyopia correction. And the reason we're doing this is because we were never taught this when we were going through the training program. And so I thought this would be a good one to really give us a taste of what we do in the real world. Before we start, just an acknowledgement of country. RANSCO members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of the country. We acknowledge their continuing presence and their contributions made to the college and the communities we work in. We will respect past elders and communities and will continue to live, work, and interact in a respectful manner with present and future elders and communities. The RANSCO Reconciliation Action Plan reflects this message of its First Nation engagements. So the first part today is a little debate. And what I've asked our three speakers to do is to champion one type of lens at the exclusion of everything else. I mean, clearly it's not a reflection of real life, but I'll get them to start just so that you get a taste of the different options and what the strengths and weaknesses are, and then there'll be a debate afterwards.
So before we introduce our first speaker, we're going to try the live polling to see how that's working. So we'll get the first question up. So if you can get your app through, that should come up shortly. We're going to try and gauge the audience response prior to the talks on what sort of type of lenses do you use normally. There we go. Very good. As you can see, results coming in. And we're going to see if our speakers are going to sway the audience after.
Yes.
Making my job tough for me.
Yeah.
This is good for us. People not using multifocals are good. You can teach them.
Alrighty, so we've got monofocal and EDOF there. Nick's got a tough job with multifocals, trying to convince everyone. So we'll see how that changes later. So I'd like to introduce our first speaker, Dr. Andrea Eng. Thank you, Andrea. Andrea is a corneal and refractive specialist at the Alliance Eye Institute and the Alliance Laser Vision and the Royal Perth Hospital. And she's also the QEC chair in Bransco, WA. And she's an examiner of trainees as well. Thank you for your talk today, Andrea. Let's see how we go.
Well, thanks very much, Chameen and Bernardo, for inviting me to this young fellows group. Being a middle-aged fellow, I feel very privileged to be part of the Younger Fellows Symposium. So I've been given this topic. If I had my way, I would ever only insert a monofocal. And you know, let's face it, monofocals are the best. And I'll be presenting these 4 arguments, and by the end of it, I'm sure you'll agree with me that monofocals are the best. Number 1, best optics and best quality of vision. Number 2, suitable for all eyes. Number 3, we can't predict the future. And number 4, monovision is rehearsable and reversible. So, you know, we know that with any type of lens correction, the more you try and get reading spectacle independence, the more focal points you try and create, the more trade-offs there are. And if any rep or anyone tries to tell you otherwise, that there's a free lunch situation here, there just isn't. So we know we have monofocals, which have the best optics, the best quality, the least side effects. You do have monovision, you have extended depth of focus lenses and multifocals. So really, is this trade-off worth it? You know, there is no free lunch. There's no perfect solution for presbyopia. So if you don't want to wear the reading glasses, let's face it, you may have to put up with some night glare and halos, reduced light transmission, reduced contrast sensitivity, waxy vision, pupil dependence, and all the lousy things that come along with these multifocal and EDOF lenses. And you have my esteemed colleagues here, the beautiful and smart Tanya, Trinh, the charismatic and enigmatic Nick Toalster, and they're going to throw all these fancy terminology at you and try and bamboozle you with things like non-diffractive X-wave technology, neuroadaptation, pupil-independent performance, and all this kind of stuff. But don't be don't be fooled by them. I mean, look how suave and cool Nick looks there. I don't think you can trust this kind of person. They're going to talk to you about the rings of diffractive technology. Well, let me tell you, these rings have been around a long time. You know, we learnt about them in Lord of the Rings, in Middle-earth. 20 rings were created to rule the world, to enslave the men of Middle-earth, to corrupt them. And more recently, Amazon Prime gave us Powers of Ring. Who's watched Powers of the Ring? Amazing, a very addictive show, and just as addictive as these rings of diffractive technology. But my argument is these rings are evil and give you unwanted photic phenomena, such as glare, flare, halos, starbursts, and this is because of the off-axis light that these rings create. And the more multifocality you try and get, the closer the near ad, the greater the peak of the near ad, then the bigger the halo. So do you want your patients to be seeing no halos with monofocals at night, or do you want them to be seeing these terrible, severe halos here through a multifocal lens? And we do know that with these types of lenses, you do get reduced light transmission and reduced contrast sensitivity. So where does this waxy vision come from? At the end of the day, the light is split. When it enters a lens, it's split into the different focal points, whether it's diffractive or refractive technology. Whereas with a monofocal, you can see in the first diagram, you get a sharp, crisp focal point, and 100% of the light is going towards that one focal point. The IC8 works a bit differently, and you can see with that one ring of evil that it reduces light transmission overall. So, if we put these lenses in, you're going to have to be willing to exchange some of them, and no one wants to do a lens exchange. My argument is that monofocals are suitable for all eyes. Would you put a multifocal in any of these eyes? Bad keratoconus, pellucid marginal degeneration, post-PK penetrating keratoplasty. And look, I'm a corneal cataract refractive surgeon, and I don't really know too much about the retina, but even I wouldn't put a multifocal in these lousy, retinas with diabetic retinopathy and epiretinal membrane. And I'll present a case here, a 70-year-old patient with Fuchs dystrophy. And he came in to see me, and his right cornea was all cloudy and edematous with endothelial decompensation. And I had a look in, and lo and behold, his original surgeon had put a multifocal lens in that eye. So anyway, I went ahead and did the corneal transplant in the right eye, and then I did the left combined DSAIC cataract surgery and put a monofocal in his other eye. And which eye do you think he prefers to see from? So he refers to his right eye as the bad right eye, the one with the multifocal, and his good left eye with the clear, crisp monofocal. Point number 3, we can't predict the future. Okay, so, the average life expectancy in Australia is increasing. At the moment, it's 81 for men, 85 years for women. Yay, women. The mean age of cataract surgery, this was the Blue Mountain study in 2008. It was 76 years of age, and I'm sure that's getting younger. And we all do, some of us do refractive lens exchange, and these patients are usually 50, 55 years of age. And this lens that you're putting in someone's eye at the age of 50 needs to last them a lifetime. What if they developed AMD, glaucoma, diabetic retinopathy, etc.? Would you have wanted to have put a multifocal lens in their eye? And we also know that people's eyes aren't stable. So yes, you could get a perfect result for the first 6 months after you put the multifocal in, but we know there's a drift of corneal astigmatism towards against the raw astigmatism after 10, 20 years. And you might say, okay, well, this study showed only a 0.18 drift, 1/8 diopter drift after 10 years. But what if you've got a multifocal? And multifocals really don't tolerate more than about half a diopter or so of astigmatism. And I ask you, how often do you see a patient come into your rooms wearing glasses and they're pseudophakic, and then you look at what lens they've got in their eye and it's a multifocal? So something's happened down the track where they find that they need some help with glasses, even though they've got some sort of multifocal lens in their eye. My last argument is, if you do want to try and correct some presbyopia, how about monovision? A tried and tested strategy. And you can either do modest monovision, which is about minus 1.25 to minus 1.5, and you can also do true monovision, but I would reserve that more for people who've been wearing that, say, with their contact lenses and they've neuroadapted to that. And Professor Barrett is a great proponent of monovision, and he did a study that looked at patient satisfaction after that, and it's very good. And another thing I like about monovision is that it is rehearsable and reversible. So you guys, you can do monovision and you can relax. R&R, you can rest and relax when you've done monovision, unlike the people who are putting in multifocals, spending all the chair time with the patients, worrying about the lens exchanges and things like this. With monovision, you can actually rehearse it with the patient. You can show them this is what it's going to be like. And it's also reversible. So at the end of the day, you just put on a pair of glasses, it's reversible. Or if they want a surgical solution, you can do LASIK or a piggyback lens. And this is actually a picture of Dr. Peter Sumich. I heard him say this at an Oscris, that it was rehearsable and reversible, and that stuck with me, which I think is a very handy way of thinking about monovision. So, in conclusion, monofocals are the best. You should stick to monofocals. And the last thought is, which lens would you choose to have in your eyes? Thank you.
Thank you, Andrea. That was a great talk, defending the title of the monofocals and introducing the battlegrounds of Middle Earth to our next contestant, Tanya Trinh. Tanya is a cornea and refractive surgeon specialist based in Sydney. She works at the Sydney Eye Hospital, and she's completed a fellowship in Canada, University of Toronto. Thank you, Tanya, who's going to introduce us the EDOFs.
Thank you. So Team EDOF, by and far the foremost front runner in our poll today. I'd just like to point out that my colleague, my learned colleague here, Dr. Andrea Ang, what absolute preposterous nonsense. If I had my way, I would only ever insert an EDOF lens. And it's my passion to speak to you about it today because it does reflect a lot of my daily practice. Now, I do love and treasure my colleagues, Dr. Nick Toalster and Dr. Andrea Ang, most dearly, and all of my humor today is meant to tongue-in-cheek. So the monofocal. So IOL selection is a little bit like Tinder. When you're going through the plethora of options available to you, swipe left, swipe left, swipe left, what do you choose? And now you've all heard Dr. Ang extol the virtues of the monofocal lens, which is tried and true in the most of your training in the public system. But what you don't know, same on Tinder, is that you've got to watch out for red flags because things aren't always what they seem to be. It might be a face of an angel. Is this something you're going to swipe right on, the monofocal lens? But she's actually got the heart of an EDOF supporter because about 10 minutes ago, she just gave a talk today on the role of EDOF lenses that she uses on a daily practice. She is literally cheating on the monofocal lens. Such heartbreak. But enough about monofocal lenses because that's eaten into my time to tell you about the virtues of the EDOF lens. So top 10 reasons of why I'd only ever insert an EDOF lens. In terms of the treatment here, it's a fantastic treatment option in the presbyopic space. And the principle of this lens, as so elegantly elucidated by Andrea today, is that it's a single elongated focal point rather than several discrete foci, which is what Nick will introduce today, to enhance your depth of focus and give you enhanced function. Now, there are a range of lenses available, most of which are available in Europe and some of which are available in Australia, but essentially it gives you more range than a monofocal lens, and that's reason number one. If you can give patients something a little bit extra, morally I would argue that it's ethical to do so because that's what you're going to want when you're going to get to that age, is you're going to want something that enhances your function and not just a part of it. Number two, EDOFs have a less dysphotopsia profile compared to multifocal lenses. So if we looked at measures of visual disturbance in patients receiving EDOF lenses compared to multifocals, there's quite a lot of literature out there to suggest or that demonstrate that the dysphotopsia profile is much more forgiving than a multifocal lens. Reason number three, EDOFs also have a better visual quality than our multifocal compatriots and on par with multifocals. So several optical bench reports, that's basically when they're putting the lens through a range of different optical simulations. They're looking at what actually passes through and looking at the dysphotopsia profiles. And there are several studies, both in the scientific and also in the clinical space, that demonstrate this. Number 4, EDOFs have fantastic utility in eyes that have subtle controlled disease. Now, traditionally in your race exams, you would have been told that you should never put it was probably a misterm about a premium IOL in an eye that has subtle disease, but you can push the borders in subtle ERMs, mild glaucoma, well-controlled diabetics, all of these conditions that may not become an issue until quite later on and may never become an issue in their life. Why would you not give them the added function of having a little bit of enhanced near? The refractive optics of EDOFs also have nicer blend zones than multifocals. So instead of having discrete foci or discrete zones of clarity where you get a dropout in each area, the patients enjoy a much more seamless experience. And when you can mix and match between the different strengths and different ads, you can actually find a nice blend between the two eyes of the patient. And the patient uses both eyes together and they don't notice too much in terms of any dropout, and much less compared to a multifocal. EDOFs can also give you that extra near. So a lot of people like to say that, look, EDOF is good, but it doesn't give you that much in terms of reading vision. But if you're, this is just a couple of emails on the Worldwide Refractive and Cornea chat forums, Vivity lens, which is one such lens. But if you're actually able to offset this in the non-dominant eye, you actually are getting quite good results. So you're using the best of both worlds in terms of monovision with the EDOFs, with the nicer optics of these lenses. Number 7, EDOF lenses are more forgiving with small refractive misses. So there's nothing more annoying when you're putting in a multifocal lens to find that you're just that little bit out and the patient is absolutely miserable and you've done perfect surgery and you really don't want to do an IOL exchange. So the multifocal retreatment rate in some studies can be as high as 11%. So it's a massive pain in your backside if you're confronted with one of these patients when you know that you've done your best, because really we can't always help where the ELP is going to rest. But they are much, much more forgiving in terms of that landing zone. And that's just another study reinforcing that. So on a practical basis, EDOFs take a bit of chair time, but a lot less chair time than your multifocals. Your time is valuable, and as beginning surgeons, I'm presuming if you've come to this symposium today, you are the rate-limiting step in your clinic for your time and income production. And having a solid product that performs consistently well makes it much easier to counsel and set expectations, because you know they may not get that much near, so you know to literally put it into your conversation. You're not going to miss that. And so less chair time, but with the same level of patient expectation, or an well-informed patient, is a win for you. EDOFs are also a fantastic practice builder for those of you venturing out into the presbyopic correcting space. So in your first year or so, you want to be building your own brand, and you want that to be based on a foundation of excellence. Most of you will not have had any formal refractive training unless you've pursued that in your fellowship, and a lot of you will be still finding and refining your refractive consultation or conversation with your patients. So you do not want to be performing a bunch of IOL exchanges for your patients in your first couple of years out and explaining this to not only the patient but also to the person that referred it to you. EDOFs can also do all of these things, which I don't have time to go in for today, but when we speak about the multifocal lens, which Dr. Nick Toalster is about to introduce to you, I want you to be careful about the possibility of falling for fake news. Check your facts. These dimples might be to die for. Would you swipe right? But are you really going to trust a glaucoma surgeon to tell you about the refractive optics of a multifocal lens and the use in their practice? Because at most, that love story on Tinder is going to be a little bit like Romeo and Juliet, and essentially a tragedy. With deepest love and respect. Thank you very much.
Thank you so much, Tanya, for giving us a good swipe out of our candidates. We'll introduce Nick Toalster now, who is a cornea and glaucoma specialist at the Royal Brisbane Hospital, who's going to defend the multifocal point of view. Thank you, Nick.
Well, thank you, Tanya and Andrea. I'm here to let you know that every single one of your patients deserves a multifocal. In fact, my learned colleagues have been committing crimes against humanity with every lens that they've inserted that was not a multifocal. And I will show this to you today. But before I do, I have a few disclaimers. 99.9% of everything that I may say may or may not be true. And you should not think for yourself. you should take what I say as gospel and translate it to your practice directly because I say everything correctly. And I have no financial disclosures, money does not exist in my life, and I'm not influenced by industry or representatives. In fact, I've never met one. Moving on. Spectacle independence is a worthy goal. No, it's more than worthy, it's a human right. We need the ability to see. In fact, it's an increasing necessity in our lives, and in your working lives and beyond, it will be something that plagues you, and you will come to understand the necessity of multifocals with every passing year. I certainly am. And the current multifocal technology available to us is a golden era. We have the technology now, we should be implanting them now, and we can. So, why are they needed? Well, there's an increasing rate of presbyopia, as we know. The demands on near vision are increasing as our reliance on personal electronic devices and computers increases, but also, as Andrea pointed out, we have an aging population. That's not only our older patients who suffer from cataracts, but also the working population. If you think about it, that working population is being increasingly burdened by presbyopia. The age of retirement in Australia by the year 2035 is looking to be pushed out to 70 years of age. So this affects you. That means 40 plus years of burden of presbyopia, and we can do something about that. A recent study in 2019 by Hu et al. Looked at the financial benefit to not only patients but society as a whole were we to implant multifocals in every patient. And they compared the financial outcomes for society on a quality adjusted life year basis of monofocal implant and spectacle dependence versus multifocals. They proved that there is a 99.9% chance of benefit by implanting multifocals, a clear benefit. And if you think that isn't a strong enough argument, then the benefit to individual patients' freedom is clearly one. Also, the demands of our patients are ever increasing. With each good outcome we produce, it encourages their friends and families that they need a good outcome. And so we need to raise that bar, and multifocals can do that. So let's compare the options. Multifocals, EDOFs, have limitations. We're told again and again that we get poor visual outcomes with multifocals, but that's just not true. In fact, monofocals give us poor visual outcomes. We can see that, sure, if you're talking about getting 6/12 or better, there's a fair chance that you'll get that, but a large proportion of patients, upwards of 40% of patients, may not achieve close to 6/6. And really that's what we need to be targeting. That's functional vision for patients in today's world. And there's a large rate of dissatisfaction. Up to 15% of patients are dissatisfied with their refractive outcome after monofocal implantation, and clearly that's not good enough. On the right of the screen, you can clearly see the black bars representing the multifocal lens groups do far better in terms of their spectacle independence, being 300% better than monofocals, and in terms of their overall distance visual acuity, being almost an order of magnitude better. People just see better with multifocals. This concept that you're going to get waxy vision, reduced quality of vision is just not true. There are a number of studies that show that both uncorrected and best corrected distance visual acuity are equal, if not better, with multifocal patients. And this is over all distances. And clearly we're not even talking about near vision, which only multifocals can give you. On the right of the screen, you can see an infographic, and clearly it's much better with multifocals, given the colors and the size of the bar graphs. Now, I just want to point out something that none of my learned colleagues have even mentioned, and that is the near point. Here we can see the defocus curves of the three lenses we're talking about. Blue for monofocal, grey for EDOFs, and orange for trifocals. Only one lens gives you the near point. Only one lens can give you an unaided near vision. And clearly, that is an important part of our daily lives. We need to be able to see our computer screens. We need to be able to read, and only this option allows that. But they perform better. their defocus curve is flatter. In the top graph, you can see these steep defocus curves, meaning that as patients move their visual tasks closer, the ability to see those drops off rapidly. Only the green bar has a nice flat defocus curve, allowing us to see over a range of functional visual distances. As Tanya pointed out, monofocals have very narrow landing zones, meaning that if you haven't got your refractive target right on, then you're going to end up with an unhappy patient. And multifocals allow us to achieve soft landing zones. This was a slide that I used to present to my registrars, talking about the contraindications for multifocals. Wrong. Days have passed. We've got much better technology now. These problems have been solved. Macular disease, intravitreal injections. Glaucoma, MIGS. Refractive planning, well, we've got new formulas, and I don't have any psychosocial problems in my practice. Really, multifocals give us great outcomes. You can see, again, colours, bars, great outcomes, everyone's happy, spectacle independence. But also the technology is improving. Gone are the days of photic phenomenon. Sure, in the past, the first generation diffractive multifocals did have some problems, but these days, with pupil-independent designs and improved mesopic performance, we're really talking about older technology relating to those side effects. And speaking about technology, it's not just the lenses, it's all of the supportive technology that abounds today that allows us to achieve these fantastic results for multifocal patients. It's things like Rexis-centered lenses, it's swept source OCT, it's digital alignment of lenses that allow us to get these perfect outcomes. And with all of this new technology, better treatment for tear film and ocular surface, accurate biometry and more detailed biometry that allows the multifocals of today to shine. We really are living in a golden era of multifocal technology. So clearly, if you're not putting multifocals in every single patient, you're committing a crime against humanity. Patients need it. They need to be able to see, to read, and to work. Vision is better with these lenses at all distances, and I won't hear otherwise. Dysphotopsias are a thing of the past, and we have the technology now. Just do it.
Thank you so much, Nick. Before we get you guys to vote, after this lively session, we'd like to open to the speakers to actually tell us what do you truly do in your practice, because we know that doesn't actually, if you had your way, you couldn't fit one single type of IOL. So maybe Andrea, we can start with you.
Thanks for that slide, Tanya, of me talking at the lunch session about EDOF lenses. Yeah, I actually did do an audit of the uses of my lens the last 12 months, and I found that in cataract patients, I was putting about 35% EDOF lenses, maybe 5% trifocals, and the rest monofocals. And then in my refractive lens group, it was 80% EDOF and 15% trifocal. So I think, I mean, we can talk about the pros and cons, but yeah, I think EDOF is featuring more strongly these days. Yeah.
Tanya?
In my clinical practice, I would probably say I'm close to about 90% in terms of my EDOFs. The lens technology in the EDOF range is getting so good now, and with the additional adds of up to +3 and achieving that blend, the results have come through quite nice. The other option before that was available in the toric version of the particular lens that I use was offsetting it by 0.5, which would also get them that additional near, and a lot of patients are quite happy with spectacle independence, and I don't have the headaches of all of the dramas of the conversation and the lens exchange and the glare and halos as well.
Nick?
So contrary to my speech, you might be surprised to hear that I don't only put multifocals in. So my practice is split up between my cataract refractive patients and then those that have a lot of cornea and glaucoma disease. And so in my cataract refractive surgery patients, I probably put in about 80 to 85% EDOF and a bit of sort of 10, 15% diffractive multifocal, and then in my patients that have significant glaucoma and corneal disease, I almost exclusively use monofocals.
So I guess the follow-up question to that is, say you've got a 50-year-old presbyope, and that's their main reason for coming to see you, and they're really keen to be truly spectacle independent. Do you choose the EDOF with the mini mono? We'll throw it up, Andrea.
You're talking about a pure emmetrope presbyope who
Yes.
has great unaided distance vision, and I
So
asked them about
the worst
this.
kind of patient.
Yeah,
they're
yeah.
I
I dissuade them from any surgery. I just tell them there is no perfect solution for presbyopia, and yes, you can have a refractive lens exchange, yes, you can have an EDOF or multifocal, but will you want to then put up with the side effects of those lenses, given you have great unaided distance vision now?
Nick, next.
Yeah, I mean, I agree. You've got to be very careful in that scenario. It's a hiding to nothing. I do it on occasion, and it's after a good long 25-minute counselling session, truly. It's a long counselling session, and often I make them come back and do 2 or 3 counselling sessions. And then my approach in that has been to do split EDOF diffractive, so a refractive EDOF in one eye and a diffractive multifocal in the other eye is my go-to at the moment.
And Tanya.
So the mix and match technology works quite well. During my fellowship, we were doing quite a lot of symphony in the dominant and the Technis multifocal in the non-dominant eye. But you would still get unhappy patients. With the emmetropic 50-year-old with excellent unaided distance vision, I will almost actively, I would agree with you, actively dissuade them from going ahead with surgery because nothing really can replicate a lens that is relatively clear. And my staff who are sitting in the top left-hand corner to their chagrin, I will actively tell patients to go away and come back a little while later. So there are many other good options that they can explore as a temporizing measure. And I think, all of us would agree on this panel that it's the first rule is first do no harm, and knowing when to say no is just as powerful for your practice as saying yes to the right patient. Because I will freely say to my patient that it doesn't really matter to me what surgery you have or who you have it with. You could go down the road and have it with someone else, but what matters to me is you understand the technology that is being implanted into your eyes and that you have some control over that, saying you understand what it is that you're signing up for, and I'm very clear about that.
And that's a different scenario from somebody with a cataract, who's emmetropic and presbyopic. Then, they've got degraded vision from their cataract and they've adapted to their cataract vision. So I think then the conversation is different, and it could be valid putting in a multifocal in those cases.
Well, that was going to be my next question. I mean, we've heard about the benefits of EDOFs. When do you then choose a multifocal? What's your patient of choice for a true trifocal?
So I think they've got to have a pretty strong motivation to have a good near point, and I carefully differentiate saying a good near point to spectacle independence, because it doesn't necessarily mean that they're going to be completely spectacle independent, and they have to understand that. So if they're keen and motivated to have a good near point, then that's a goal that we can try to achieve, but they've still got to be aware that there's drawbacks, potential enhancements, and still a potential need for glasses.
Yeah, I would agree. If they've got a suitable eye, a decent cornea, high order durations less than 0.3, 0.4, pupil offset's not too high, and they're very highly motivated and they're willing to put up, you do the counselling chair time with them about the side effects, then I think that is fine to proceed with that.
Tanya, do you have?
I was interested to hear in Dr. Lahoud's opinion as a multifocal passionate supporter.
I am passionate. I feel like a bad human being because that 50-year-old presbyope isn't leaving my rooms faking. So if they've made the effort to come and see me because they hate their life and they want to see things better, I think those particular people do really well with bilateral trifocal lenses, because a lot of them want to be able to, they want true spectacle independence, and that usually means reading vision. So I do a lot of bilateral trifocal implants in very young people, and I'm sorry for my sins.
And sorry, do you counsel them, how do you counsel them differently? What's the difference in the way you counsel that patient to, the cataractus patient you're putting EDOFs in?
Yeah, I talk to them a lot about, there's a lot of talk about trade-off because you aren't getting away from halos and glare. They're real. I know that you do know they're real, but they are real. And they do go away to a certain extent, but there's a trade-off. And if I talk a lot about trade-offs, so, monovision, the trade-off is you need reading glasses. EDOFs, the trade-off is you may need reading glasses as well. And trifocals, the trade-off is halos and glare. So I do a lot of that counselling and discussion about that. I usually talk about pain. If you're in pain from your vision, like psychologically, then you will probably put up with that. But I do agree, like a very early presbyope that's not that bothered, but their optometrist said, come and see B and he'll sort you out. I do have that chat. But if they're truly, they don't like what they've got, I think it's reasonable to do an early lens exchange.
Yeah, I'd be in more Ben's camp because my experience is that I use quite a lot of multifocals, so it'd be over 50%. And the reason being is that I had a run of EDOFs for a few years, but what I found was with the mini offset, there's actually quite a lot of chair time. 6 months later, doctor, I'm 6'9", 6'7", 5 in the non-dominant. Why is it not as good as the other eye? And, you can go through that. You can massage that in your practice, but if they truly want spectacle independence, very, very similar to Ben, it's a lot of chair time up front, a lot about the trade-offs. You can, as Peter Sumich said, you can simulate monovision, which is fantastic, but, some people really need that stereopsis, and I think we're not great at determining dominance. There's cross-dominance. So for some patients, the only option is a trifocal. And what I found with the EDOFs was some of them were coming back years later and wearing glasses all the time. And the usual scenario is they picked up their husband or their wife's readers and, it's so much better. So they're just back on the reading train. And EDOFs aren't without aberrations. So, I just don't, they either want the full thing or they're happy to wear glasses. So there's sort of this, I don't know the EDOF zone, That's been my experience.
And I guess the last one before we move on is, I'll open it to everyone else. So Elaine, Ben, John, what's your split in terms of multis, EDOFs, and monos?
I mean, the first thing I'll say is that there's no perfect solution. You're never going to get your vision again as if you're 16. So there's always a trade-off. That's the first thing I say. So then I go through, if they're interested in basically being a bit more spectacle independent, going through the monovision route, telling them that, well, this is what my mom did and my father. They are out of glasses 90% of the time. So 10% of the time in front of the computer when they're sitting there doing a lot of computer work or reading, yeah, put on your pair of glasses next to your table, put them on, you're as good as go. And you just leave the glasses there. When you're out shopping, when you're looking at the price tag in the supermarket, everything is fine, you don't need glasses. So that's one camp. So then the next step would be the EDOF camp, which is they want to be, seeing far. I say, well, you can see in the distance well, and intermediate vision is good. That means computer distance is good. But if you were to sit down again for an extended period of time reading, you might have to leave your reading glasses on your table, okay? There is a little bit more glare and halos associated with EDOF lenses. And then the next step down would be the trifocal route, where again, we'll be discussing the glare and halos, which, and also a little bit of waxy vision. And typically, they need to be eyes that are perfect. I don't really want to put on an EDOF lens, trifocal lens in a patient, which I just saw recently, with a trifocal lens in a 20-year-old proliferative diabetic retinopathy with requiring monthly injections. And she's seeing like 6/18. When you know that without that trifocal in there, she will be seeing at least 6/9. Not perfect, 6'9".
Sorry about that, that's my patient. My split has really changed recently because when Vivity first came out, my pendulum swung towards putting Vivity in everyone, and it went up to probably 80%. And then I realized that I was getting a few 6/9.5s and I couldn't explain them. I wasn't that thrilled with the distance vision. So my pendulum has swung back to using fewer Vivity lenses or EDOF lenses. And if you see the data from the Clarion toric, and I'm just selling my poster here, the intermediate vision is remarkably good. So I've actually swung a lot more back towards using monofocals, whereas I may have used EDOFs before.
feels like I'm just copying Ben, but you know, I almost exactly the same experience. You know, I used there was a lot of patients were going down the EDOF route, and then found that they actually caused quite a lot of waxy vision for distance. The 6.9, 6.75s just couldn't refract up, optimize the tear film. Patients just the visual quality just wasn't there. I think when you've got someone sitting down talking about the multifocal, they may have all those issues, but they can still see well in the distance and still read. The focal points are really hard and they're fixed. Then once EDOFs were sort of off the table, I've had, reasonably good success using something like iHance in the non-dominant eye. There's a little bit of the not quite maybe as good as just the true monofocal lens, but I think for the monofocal crowd, there's more and more patients that just want a little bit more, and for various reasons, maybe mild epiretinal membrane, dry eye disease. But I think there's just no substitute for the chair time, and as Tanya sort of said, just discussing all the options, and maybe they need to think about it, and there's definitely no rush. So my practice is probably about 50, a little bit over of trifocals, less than 5% EDOF, and the remainder sort of monofocals with some monovision thrown in there.
Can I just make a point? I think we do need to be careful when we talk about EDOF lenses, because extended depth of focus, there's such a huge range of them and they have very different technology. So if you're starting out in this space, I mean, you really should be just looking at the different technology out there. You have diffractive, you have the Symphony lens, you have the Vivity, you have now, Graham Barrett's Rayner EMV, which is a positively spherical aberrated lens. And then you have the IC8 aperture lens, you also have refractive EDOF lenses, and they all have their pros and cons, strengths and weaknesses. So you just got to find a lens that you start using, get comfortable with, and are happy with the results and are happy with the trade-offs. And I think each of us have different preferences with that.
Great point, Andrea. So before we open to the floor, we're going to do a second polling question now, so we can finally decide who our winner is, who swayed the audience better. So we're going to do the same question there, after we've heard everyone's point of view, and it's interesting to see people with different points of view, different practice styles.
But it's a great talk.
We're still waiting. If you can log in and vote again. And we've got 2 microphones in the middle and one up there. If anyone wants to make some questions, please just direct themselves to the microphone. Alrighty. Well, we'll wait for the questions to come through, so we're not going to establish the winner just yet. Yeah, please.
I'm Leo Sheck. I surgeon in Auckland. I mainly run a retinal practice. So one of you mentioned the J&J iHance lens, which I find quite useful. It's classified as a monofocal, but it's got a little bit more of a depth of focus. Do you have any more comments about it?
So iHance is becoming my monofocal and a little bit of something for my patients that would either not be, I've had quite a good EDOF experience. I don't use the Vivity. I've had the same experiences as my colleagues up here on the table, where they're just not quite hitting the refractive targets. And we are looking at trying to refine that with our routes, but as a result, I haven't used a lot of them. But the Accunex Teleon lens has been quite a good quality in terms of distance vision, more patients hitting 6.5, very accurate and on target with those lenses, and the quality patients have been really happy with. And I should say that the area of Sydney that I work in, patients are extremely fussy, so the quality conversation is a big one. I try not to overemphasize it so much, but in terms of your question, for those patients that are looking for something a little bit extra with my mild epiretinal membranes in one eye, but the other eye can have an EDOF, then we have that conversation. Look, I can't give you everything that you want in that eye, but I can give it to you in your mild ERMs, stable diabetics, mild glaucoma patients, people with maybe, your early drusen that's not quite AMD. I find them quite helpful in those situations, but it's not going to be a life-changing experience for them.
Can I say something, Bernardo? Hey, Leo. I got in trouble recently for saying that if iHance was a superhero, it would be Batman because it has no superpowers. And I haven't found it to be particularly useful, but I'd just like to take this opportunity to apologise to J&J. Thank you.
Yeah, look, I mean, iHance, it behaves more like a monofocal, but it gives some, I would describe it as giving some functional intermediate, okay? If you want efficient intermediate, then you have to use a true EDOF, like a Symphony or some other.
Hopefully that answers your question. So I'm going to introduce our next session now, which we're going to talk about multifocals. So I'll introduce Associate Professor Chameen, who is a cornea and refractive surgeon at Westmead Hospital. He's also an HMRC investigator. Thank you, Chameen, for co-chairing this with me and also speaking.
Thank you. As you probably guessed, we all have slightly different practices. And to give you an idea, I started, embarrassingly, just under 10 years ago. And when I started, my population were primary 70 and 80-year-olds, and I was doing a lot of just straightforward monofocals. EDOFs weren't around then. I hardly ever put a trifocal. My practice has become much younger, and there's a heck of a lot of 45s to 50-year-olds who are coming in for true presbyopia correction. And so when I looked at my numbers, I'm actually about 55 to 60% trifocals, 20 to 30% EDOFs, and the remainder monos or specialty lenses like IC8. So today, and one of the reasons why I wanted to do this is because I never got told about what the ideal lens or ideal eye is for these multifocal patients. So the purpose of this particular talk is to tell you or give you some idea of what that perfect eye is when you're launching on your path towards multifocals, if you decide to do so. Then you can pick the right patient to get a good outcome. So I guess the first question is the ideal eye for a multifocal just a phakic eye? And as Ben said, do we leave them phakic with the curse of phakia? The answer is no, we don't leave them there, but you've got to pick the right patient for it. And the way I think about it is there's certain factors that you have to consider. By far, the most important factor is patient factors, whether it's the right patient. And this is a big topic, and it's a difficult topic, which is why I left it to John. What I'll talk about is what are the things in the eye that you can focus on to tell you that they've got a good chance of being happy in a multifocal. And there's actually a whole variety of things to think about, but the way I break it down is basically macula, nerve, cornea, and I'm cornea trained, so this is the most important, think cornea. And the last thing is actually angle alpha, and I'll talk about that. The first thing you have to think about with a multifocal is you need to get really accurate measurements. With multis, which is different to the other types of lenses, you've got to hit emmetropia. You've got to neutralize all the astigmatism. It's got to be bang on. Otherwise, you just don't get the benefits of that multifocal lens. And the evidence is clear, 72% plus get within plus or minus 0.5, which is pretty good, but that means 28% are not. And the commonest reason is actually effective lens position. Now, that's a little bit out of our control, but the newer formulas that use TK, and I'll talk about that, give you better results. The other thing is, or the next common reason for measurement error is actually axial length, but this is getting better, and certainly there's evidence that the newer model IOL masters are giving much better results. And the last thing is post-op refraction and refractive errors in measurement. And one of the common reasons is dry eyes. So I'll reiterate that it's really important to address that. And we all hate dry eyes, but it's actually relevant a lot. I've got entire talks on TK, but for the purpose of this, TK is basically where you're using the anterior, posterior, and corneal thickness to determine the true corneal refractive power. And the point to make is you should be using, if you have access to it, a TK formula. The commonest one is the Barrett TK, but there's other ones. And what it shows is that you get better accuracy in your outcomes, particularly in cylindrical correction. And there's nothing worse than having a patient who's just got a tiny bit of astigmatism. That's enough to affect their vision, and they find that their vision's not quite perfect, and it's this residual astigmatism. So TK helps with that. When you look at measurement, I'm a big advocate of using multiple measurement techniques. You know, the retina guys all talk about multimodal imaging, where they look at the same macula in, 6 different techniques. I think for cataract surgery, at a minimum, you should be, I advocate that you use 2 techniques, IOL master, and the newer models are better, but also match it to pentacam. And what I do is I look at the pentacam first, make sure that everything's fine, then I look at the IOL master and compare the power and axis, and then cross-correlate that with the refraction from past glasses, for example. So a lot of this information can be found on the pentacam, and if you've got access to it, it's quite a useful device. And the spot you go to is what's known as the cataract preoperative display, and it's this box. And when you look at it, what I say is, if you can match that power within 0.3 of a diopter, if you can match the axis within 20 to 30 degrees, you know that you've just got accurate measurements, which means you can then calculate your lens with much more confidence. And you can then say to your patient, hey, look, I think we're going to get good outcomes. Now, the 4 things that I spoke about, macular and nerve are important. As a corneal person, I say this grudgingly. If your macular and nerves not working well, you're not going to get a good picture. And we've all heard analogies like the eye's the camera. If the film's rotten, the picture's bad. True. So I think there's value in OCTing everyone who wants a cataract, and just making sure that that's fine. But I also think, and this is something that I suspect is not done as frequently, is to get a really good look at the cornea and make sure that your patient, particularly in the context of a multifocal lens, is that patient who has a pristine cornea. What you really want to use is tomography over topography, because you get better accuracy. And the map you're looking at is the format refractive. And most format refractives have back elevation, front elevation, thickness and curvature, and there's normative data. And so the big thing you need to look at is that back elevation. If it's greater than 15 microns deviation, you're thinking ectasia or minor ectasia. And these are patients that are not the ideal patient for a multifocal. So that's that back elevation, 50 micron deviation. The commonest thing that patients don't know about, but you might detect when you start doing this, is forme fruste keratoconus, where you can see there's a 21 micron deviation on the back elevation. That's the patient you want to avoid. And if you do put a multifocal in them, you find that they're just suboptimal. They'll, instead of getting like 6.5, 6.6, they're like 6.7.5, 6.9. And instead of getting crisp vision, they're just slightly off. And it's the aberrations in the cornea compounding the aberrations induced by a multifocal lens. The next thing you have to do, I'm just checking my time, is just make sure that the small things that are measured in the cornea are suitable for a multifocal. And once again, it's this cataract pre-op display. What you're looking for is the total corneal or the spherical aberration and the irregular astigmatism. And if those are under 300 microns, you've got a good chance of getting a happy patient. If they've got a high spherical aberration, they will comment to you that they get a lot more nighttime symptoms, whether it be glare, halos, but as well as that, they might say, look, the vision's not very good at night because of the spherical aberration. And the irregular astigmatism just degrades quality of vision across it, everything. So they're the ones who, if they've got a high irregular astigmatism, they're just not getting the mark and you can't refract them up. The last thing that I think is worth addressing is actually angle alpha. There is a bit of a debate now whether kappa or alpha is more important. And I guess I'm in the camp that alpha is more important. Alpha's the angle between the optical axis and the visual axis. And the reason I say that's more important than kappa, which is more pupillary, is because IOLs tend to sit in the center of the bag. I mean, you can shift them around a little bit, but by and large, they're in the center. And that center of the bag crosses with the optical axis. If the visual axis correlates with the center of the optical axis, then you've got an increased likelihood that they're looking through the center of your IOL, which means they get the benefits of the multifocal lens. Whereas if they're looking through a diffractive ring, they're just not going to see well. So where do you find that? That's actually in the IOL master. It's that back sheet that no one looks at. But if you hunt through it, you find this IXIY. And the absolute value of that should be less than 0.4 of a millimeter. And there's evidence that once it hits 0.4, the quality of vision drops by 30%. Once it hit 0.7, it's more like 50% attrition. So the summary of the process that I think to pick that ideal eye for a multifocal is, first of all, make sure the patient is the right patient, and John will talk about that. Make sure your imaging is correct so that you know that you've got accurate measurements. Make sure the health of the eye is okay, so that's the macula, the nerve, and most importantly, the cornea. And then the small things, which is the spherical aberration, irregular aberrations, and I think angle alpha is very important. And it took me a long time to get this acronym right, but if you can do all of this, it'll be a piece of piss. Thank you.
Thank you, Chameen. So, as you may have noticed, we started now this session talking about the multifocals after we've talked a lot about mono and EDOFs. So before I open the floor to questions and we do some more polling, I'll introduce Ben for the next talk. So Ben LaHood is a cornea and refractive surgeon based in Adelaide, working at the Queen Elizabeth Hospital. He's going to talk about which multifocal lens we're going to use, particularly the hydrophilics. Thank you, Ben.
Thanks. All right, thank you. So I'm going to explain why you should only use hydrophilic multifocals, IOLs, and it's kind of loosely multifocal. So multifocal will cover trifocals, EDOFs, bit of a range. Financial disclosures. I do some work for a hydrophobic prone company and a hydrophilic prone company. And my personal disclosures, to keep them both happy, I do use a bit of both. So I'm not really that biased in any direction, but today I'm going to be saying why you need to use hydrophilic. So all the best things in life are mainly water. It was quite hard to think of things that mainly contained water that everyone liked, but Earth is one of them, and it's got a picture of New Zealand, so it's great. The Zeiss AT Lisa is also something that's full of water that everyone should like. This is a lens that fits through a 1.8 millimeter incision. It's stable in highly myopic eyes. I'll show that that's the case. It's got fantastic day one results, better than, or anecdotally for me, any other trifocal that I use. And it's very stable long-term results. So it's been around for over 7 years and has published results on that long. And it is stable, maintains very good vision long-term. Other good things that are mainly water. I found one more. What about the Teleon Femptis? This is another lens that's hydrophilic that everyone should love. It fixates within the capsule and it's a multifocal. It takes out any concerns about effective lens position that Chameen was talking about. We know exactly where it's going to sit, so we don't have to worry so much, and it stays in a stable position long term. I was really scraping the bottom of the barrel. What a melon. My Google search history is a bit weird, but that's fine. The First Q add-on trifocal IOL. This is a bit of a game changer. This is a sulcus lens that you can retrofit an eye. So someone that's had cataract surgery many years ago didn't have the chance to have trifocals, as everyone should, as Nick explained clearly. Some of those people that missed out on their human rights, they can get multifocals put back in. They're incredibly stable to rotation. So this is a sulcus lens of choice regardless of whether you use trifocal or not, because it doesn't rotate like a sulcaflex may. It's very easy to implant and easy to remove. So you can try it, you can rehearse it. I am 70% water. Mainly, well, maybe 70% KFC, I don't know. But like a lot of water, there's a lot of water in there. So why are trifocal IOLs, the hydrophilic versions of them, why are hydrophilic multifocals better? Why should you be using them? Number one, the most predictive refractive outcomes. They can fit through a really small incision, and it's really simple. Small incisions give very small surgically induced astigmatism, which gives more predictable results, better results, and these are the lenses that are particularly susceptible to residual astigmatism, so you want to minimize that if you can. I just made this diagram just to show that You know, we get taught that when you cut a cornea, it flattens exactly where you make that cut, and it steepens 90 degrees to that. It doesn't. We make a cut here. All of those dots could represent where the flattening effects occur for each individual eye. So since we can't predict it, we want it to be as small as possible. We really can't. Everything you've been taught about SIA is wrong. You can't predict where it acts. We don't know enough about corneal biomechanics. Reason number 2, they're more stable in high myopes. So you might think, well, who cares? We don't operate on that many high myopes. But when you do, they are eyes you don't want to go back inside. You don't want to be rotating a lens. They're big capsules, so they do have more potential for lenses to rotate. And the big plate haptics of a Zeiss AT Lisa lens are more stable, and it's been shown. So up the top there, we've got a C-loop haptic design, and you can see that there's more rotation as the axial length gets bigger. And for the plate haptic down the bottom, you can see that it's quite stable across the axial lengths. So they're more stable hydrophilic trifocals. Better quality vision. This is a big one. This is the whole reason people are coming to see you. Hydrophilic lenses do not get glistenings. It's really that simple. Glistenings scatter light. If you've already got diffractive optics inside your IOL, you really don't want more scatter. You want less. So if you're putting in a trifocal lens, it makes a lot of sense for it to be hydrophilic. Just a picture of some glistenings from an unnamed lens. Improved IOL designs with hydrophilic designs. So you can have the rexus fixation that I was talking about, segmental multifocals, custom toric lenses, so you can put down to 1/100th of a diopter into that, thanks to Talion, so thanks very much. They don't sponsor me yet. All right, and they have greater abilities. So this lens is amazing. Anyone that's ever been putting in a multifocal lens in private for a lens exchange, torn a capsule, booked a ticket to Mexico, got plastic surgery, changed your life, understands that you didn't have a very good option on how to fix this eye and give that person multifocality. Now we've got a lens where you can put this hydrophilic multifocal lens in the sulcus as a primary lens. So you no longer have to say to them, look, mixing and matching lenses is a great idea, and I've decided to give you a monofocal. They have greater abilities, hydrophilic lenses. So presbyopia correcting ICLs are now available for those early presbyopes, so you don't have to do a lens exchange. We've got sulcus add-on trifocals that I showed you, and we've got really high-power toric add-on lenses. So I'll show this next video. This is an eye where I've already put an IC8 lens in for an irregular cornea. They had a refraction that showed a lot of cylinder, so I'm putting in a +3, -6 toric hydrophilic sulcus IOL. And they also come in trifocal. So that's a life-changing surgery. That person, I know I always come to these events and every terrible surgery, they say next day 6/6. This is 6/7.5, so it's reasonable. This is a big reason. They're easier to explant if necessary. I hate the explanting lenses because I'm genuinely scared of doing it. I don't want to make an all right situation a bad situation. But hydrophilic multifocals are easier to explant if you have to. So here's a video of me explanting a lens that's been in there for 2 years, putting in some viscoelastic, and then amazingly, you can get underneath it, lift it up because it folds so easily. It's not hydrophobic, it's not stiff at all, and you can just lever it out of the rexus. And admittedly, they're not all quite as easy as that, but they are a lot easier than a hydrophobic lens to get out. Now I need to talk about the elephant in the room, opacification, because that's really the whole point of debating hydrophilic versus hydrophobic lenses. Hydrophilic lenses there's been a bit of a witch hunt to say that they do go opaque, but we know that there are definite risk factors for that, one of them being gas inside the eye. Now the risk of that, even with multiple rebubbling, so gas going inside the eye multiple times, has been as low as 2.5%. Now, very few eyes get gas inside them at any stage, and you're even less likely to put a multifocal lens in an eye that is likely to have gas inside it. So anyone that's got endothelial disease, maculopathy, might need a peel or vitrectomy, you're probably not going to use one anyway. So it's a risk of a risk, which I think is entirely acceptable. The smaller elephant that's in the room the higher PCO rate. So you often see people advertising, this lens has a great PCO rate, just about 0. I don't mind a bit of PCO, I've got to admit. And I think anyone on this panel that says they don't mind doing a YAG capsulotomy is probably lying. So I think that a low PCO rate, we're not talking about a flood of PCO. They do have a slightly higher risk of that, but it's actually quite satisfying getting rid of it, both for the patient and for myself. So in summary, you should only be using hydrophilic multifocal lenses because they're more predictable refractive outcomes, better optics, more variability, more just variations within the eye. They're easier to explant and their side effect profile is very good. So thank you very much. And if you want to send any abuse or thanks, you can send it here. And otherwise, I'll hand over to Elaine.
Thank you, Ben. Now we're going to get Elaine to talk about the hydrophobic IOLs, the multifocals. Elaine is cornea and retina specialist working at the Eye and Ear, and she's the head of ophthalmology at the Royal Melbourne Hospital. Thank you, Elaine.
What can I say? Lies, 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 Ben. All right, oops. I think I accidentally pressed it. Sorry, apologies. So just going to talk about which multifocal we should use, whether we should go for a hydrophobic or hydrophilic lens. And we should definitely not use the hydrophilic lens and use the hydrophobic lens. So just to re-emphasize these prerequisites, we need to make sure that we have accurate refraction, we address the toricity, we have very little residual astigmatism, we need to understand the visual needs of the patient, and then make sure they're suitable for the EDOF or trifocal or the secondary IOLs, which I'm also very interested in. So things to consider are the range of IOLs available, the ease of handling of the IOLs, whether there's glistening, and also whether there's IOL opacification. So we want a huge range of powers available. We want a receptive, IOL wrap, and they can bring the lens to you whenever required. We want to have ease of delivering the lens into the eye, control unfolding, not too fast and not too slow. We do not want lens glistening, and we definitely do not want IOL opacification and post-vitrectomy or gas. So let's do a comparison between the hydrophilic and hydrophobic lenses, looking at the fold-unfold rate, the glistening, PCO, opacification, different platforms, and also health economics. So hydrophilic lens, yes, they're fast, easy, flexible to unfold. But similarly, for the hydrophobic lenses, for all the new technology, they're, again, quite easy to unfold and control, except for maybe one which should remain unnamed, where you can walk around the room once, and it's still unfolding in the bag, but it's not commonly used. How about glistening? Yeah, true, hydrophilic lenses hardly have any or no glistening. Hydrophobic lenses do have some glistening, and not all hydrophobic lenses have glistening, only a particular brand, which is, again, unnamed. The posterior capsular opacity rate is exceedingly high in hydrophilic lenses, okay? This is like 7 times higher over a 2-year period compared to a hydrophobic lens. And this is only going to increase with accumulated risk down the track with time, okay? Whereas hydrophobic, there's a low risk of PCO. How about IOL opacification, where the entire lens opacifies? This can definitely occur in all hydrophilic lenses, especially if there's any air, oil, TPA, any manipulation, whereas this does not occur in hydrophobic lenses. There are multiple platforms at the moment for hydrophilic lenses, including the sulcal lenses, which is good and excellent, but hydrophobic lenses are catching up. There's actually increasing numbers of all these EDOF and trifocal platforms on hydrophobic lenses. How about health economics? Looking at the health economics wise, there's a lot more return visits to the ophthalmologist with hydrophilic lenses. Some may like the return visits, but we want to decrease health costs, so hydrophobic lenses is the way to go. So with glistening, what they are actually little fluid-filled vacuoles within the lens substance itself. So they actually cause decreased contrast sensitivity, okay? So fortunately, it doesn't cause a significant drop in visual acuity, unlike IOL opacification, which is horrible. Basically, you can see here, the whole lens is totally opaque, okay? And if the reps tell you, oh, but this lens has a hydrophobic surface, do not believe them, it doesn't work. It actually can calcify within the hydrophilic surface under the hydrophobic surface. So this is, every time I look at this picture, I get very upset because this is my DMAC patient. Post-DMAC, the cornea is exceedingly clear. Vision was 6.7.5, and 6 months down the track, this is the opacification in the one of the hydrophilic lenses. And she's obviously upset and wants an IOL exchange. Now, IOL exchange has a high complication rate. I don't think it's quite as easy as the video we just saw. So luckily, I have resisted and not done a YAG posterior capsulotomy, which then increases the risk of any complications happening. So what is this calcification? It is bad. It's calcium deposits. It's caused by hydrolyzation of the polyacrylate, the actual polymer. It results in free carboxylic acid, which then traps the calcium and causes biomineralization within the lens, just under the surface and within the lens itself. So quite often, it's actually misdiagnosed, and YAG posterior capsulotomy may be performed, which is again bad because it then increases the risk of complications when you want to do an exchange. So as I mentioned, gas, silicone oil, TPA, all can induce this, but it can also occur spontaneously in a small percentage of time. Okay, and the duration of all these material within the eye matters. Also, patient factors like the blood aqueous barrier, the concentration of calcium within the eye itself matters. So what you can do to decrease that opacification is to sit down there for 7 minutes and irrigate, put your foot down on the irrigation machine and get rid of the concentration of the calcium within the anterior chamber itself. And Elsie Chan has a very, very good video on this. If you want to go to the video, it's called Bubble Bubble Toil and Trouble in the video section today. So basically, Elsie sits down, puts her foot down, irrigates the AC for 7 minutes to decrease the risk of this. Doesn't completely decrease the risk, but it reduces the risk. So it's actually very important to find out what lens it is before vitrectomy surgery or DMAC surgery. So we want a very happy post-op patients. We do not want any discussion of lens exchange. I don't even want to think about whether it's easy the lens exchange or not, because I just don't want to do the lens exchange. And I don't want a risk of any lens opacification. And we also need to look forward to see whether the patient may develop issues down the track. Okay, so should we abandon hydrophilic intraocular lenses? Yes. Now, look, this is the Australian Graft Registry. Essentially, you're seeing that over time, every year, there's an increasing number of cornea grafts. And if you look at the types of cornea grafts, most of them are actually endothelial keratoplasty, DSECs or TMACs, where you need to put air in there. And I can tell you, my vitreoretinal colleagues are even busier than the cornea surgeons. So this is just going to increase. So there's a 2 to 25% opacification rate in hydrophilic lenses. Okay, so we should search the literature carefully and make sure we look at the entire cohort of opacification rate. And this is actually a relatively conservative, 25% opacification rate is quite conservative if you look at post gas in the eye with hydrophilic lenses. And again, in the literature, multifocal explantation rate from randomized controlled trials varies between 0 to about 6%. And the explantation risk, if you want to explant a lens, is also high. It varies between 33% and 45% if you had a YAG posterior capsulotomy before, okay? And keeping in mind, seriously, a lot of the patients coming in now, cataracts become like a commodity. They want to get rid of glasses, right? So these are younger patients. Obviously, if you're younger, if you have a lens in when you're 50, you have a higher accumulated risk throughout your life, okay? So these lenses are going to stay in you for a long time. I mean, the patient's eye for a long time. So let's look at N=1, a case study of injury of Elaine Chong's past injuries. She's a reasonably fit and denies to be middle-aged lady. So I've had a foot fracture. So I'm not a risk of a risk. I think I'm reasonably healthy. So I've had a foot fracture before. I've had falls, 2 falls when I've gone for long runs. I've 2 falls downstairs. But you say, hang on, you don't have any eye injuries. Well, I do actually. So I've had 1 soccer ball, 1 basketball to my face, a shuttlecock to my eye, and foreign body to my eye. So I'm well aware that things can happen, okay? So don't take chances. Don't take chances on hydrophilic lenses. You don't have a rewind button. So let's look at hydrophilic lenses and hydrophobic lenses. You can see on the left side, there's a whole list of hydrophilic lenses, okay? And I mean, the technology is excellent. And hydrophobic lenses, they're catching up. So let's just have a look at a few. Just to answer your question about the eye hands, this is the defocus curve you can see here. If you look at the, this is the monofocal lens, this is the eye hands, and this is the Ray 1 EMV, which is hydrophilic, this is the Symphony lens and the Vivity lens, okay? So with one of the EDOF lenses, I'm just gonna quickly run through the various lens platforms. So they all vary quite a bit, and it's really quite interesting. So I'll quickly go through this with you. So this is a near add component at the bottom with the Acunix Vario and Vario Max from Talion. This is the Acrisoft Vivity lens, which is the X-Wave. Essentially, it's two nubbins with at about 1 micron's ring in the center. This is the eye hands, where you have a 1 micron central elevation, as opposed to a Technis 1P ZC-Boo, which is a monofocal. And then you have the Symphony with, which is an EDOF lens, again, hydrophobic. I'm talking about all hydrophobic lenses, 9 diffractive rings. So how about the trifocals? You can see here the difference in trifocal, Technis Synergy, which is hydrophobic, and then the Fine Vision hydrophilic, Zeiss trifocal hydrophilic, and then the Panoptics. So again, they are better for near vision. And so Panoptics is the one on tops, and the Synergy, with 15 rings. And you can just see that the intermediate distance sweet spot is a bit closer for Panoptics. So learn from our mistakes. Use only hydrophobic lenses. I just want to show you very quickly, just for interest's sake, the different types of lenses you might be interested. So you've got, now we're moving on to hydrophilic lens, just to give you a quick taste of hydrophilic lenses, because I think they were quite interesting. The Mini Well with these kind of optics, and the Ray 1 trifocal. You've got the Lucidis Swiss Advance with the different nobules again. And also with the Precision Presbyopic optic is segmented and diffractive, which is again quite interesting. And now you've got the Evo Viva ICL, which is not available yet. It's coming out next year. It's actually a presbyopic ICL, which you insert into a phakic presbyopic lady and a person, and also the Salcoflex lens and the add-on lens, which is a supplementary lens in the eye. So thank you. Use hydrophobic lenses only. Thank you.
Thank you so much, Elaine, for defending the hydrophobics passionately. Just in the interest of time, I'll introduce John, who is our final talk. John is a cornea and refractive surgeon at the Royal Brisbane Hospital. He's going to talk to us about the right patient for the multifocal. And then we're going to have a discussion on all the multifocal talks we've had so far. Thank you, John.
Thank you very much, Bernardo. And I'll try and keep this quite brief. I think a lot of the issues we've sort of discussed, and Chameen did a very good job discussing the biometrics and the right eye. And so, I wanted to discuss the right type of multifocal patient. The baby boomers are a generation that are quite demanding of life, and I think that as we identified, they're going to live a lot longer. So they're going to retire earlier. They're very active, and so just because a patient's phakic or they've got refractive error and they're presbyopic doesn't mean that if you're holding a hammer, not everything's a nail. So we don't have to use multifocal lenses in every patient. But definitely there's patients out there, wanting more, and they're wanting it all. And depending on how your practice is positioned, if you're starting to look at presbyopia, correcting IOLs, I think you need to have a few wins, to build up your confidence and to move forward. And so, if you're usually using monofocal IOLs and a 52-year-old or 54-year-old minus 1.5 accountant comes through the door that wants spectacle freedom, that is probably not your best candidate to get involved with, multifocal IOLs and presbyopic correcting IOLs. So, trying to really work out the right patient, I think is critical. And I think the panel's done a wonderful job addressing a lot of the issues that I see. And, it's just having that time and rapport with your patients. There's been a lot of studies, and a lot of this is industry and driven, and looking at, what patients want. And there is definitely a real push for presbyopia correction. The Cantor study suggests that, up to 90% of patients, when given the options, as well as the pros and cons, are electing for presbyopia correcting IOLs. So, there's the drawbacks, which, we've, in the debate, it's been real, we said they're not perfect, that you've got to be really realistic with these patients. And I think in selecting the right patient, you've got to get a patient that can understand the pros and cons. Ben spoke a lot about pros and cons, and so did Tanya, about the different types of technology and why they may choose one over the other. And I think if your patient can understand this and, understand it's not perfect and the realistic pros and cons, then you're starting to think that this might be a patient where you've presented all options, they can really paraphrase it back to you, appreciate the pros and cons, then this might be a patient that you might think about progressing towards a multifocal IOL. So, in order to sometimes find the really happy patient, we want to try and work out who are the unhappy patients. And so, unrealistic expectations. So this is the patient that expects it all to be perfect. Just this week I had a few patients that came in and, John, I want to be able to read without glasses. And I said, can you elaborate a little bit further on this? And they, grabbed, I had like a Alpha-Gan bottle on the desk, and they grabbed it and it's got small writing on it and said, I want to get up at night, in the bathroom and be able to see this. And I mean, that's a very hard visual target in low light. It's sort of like, N3 font. So, a little bit unrealistic no matter what IOL, unless you're giving them a, -2.5, -3 monovision refraction. And if they're not informed of all the issues, I think speak to colleagues. If you're, starting to dabble in multifocal IOLs, speak to a lot of colleagues that have more experience and say, well, how does your consultation look? What is the flow within the practice? How are you starting off the consultation with these patients? Is it pre-assessment questionnaires, or is it, a set protocol that you run through with your patient? Chameen identified a lot of the issues. So, why might they be unhappy? It's tear film. Again, that, is a good thing to identify pre-operatively. Uncorrected refractive error. These patients that are electing for a multifocal IOL are doing it for a reason. They're wanting spectacle freedom. And so much like when someone's prescribed glasses, if the refraction isn't right, they're going to go back to the optometrist for a remake. And so similarly, make sure you're refracting these patients post-operatively to avoid dissatisfaction. I mentioned other pathology, and that can be mitigated if the patient's highly motivated. The dissatisfaction, satisfied patients, I mentioned glare and halo, slow adaptation, contrast sensitivity. I think those things are sort of borne out through the pre-operative discussion. Beware of myopes and too early. And I think that 50-year-old ametrope with perfect distance vision, unless they're highly motivated and can understand the risks, that they could be trouble. So, the perfect patient. So, in this discussion, there's potentially RLE patients and the cataract patients, two really different types of patient. The RLE is obviously refractive error. The cataract patient often has a drop in contrast sensitivity from their cataract. So, the things to look at, fully presbyopic. So, over 46, 47 years of age, you really want them fully presbyopic. The +2 44-year-old for an RLE can be problematic. Again, the realistic expectations. Binocularity. So, we'll frequently test the stereopsis of our patients, but sometimes if they're very mildly amblyopic, I've had good success, especially in the highly motivated hyperopic patients. The natural drop in contrast sensitivity. So when they've got a solid cataract, they're 65, 75, their BCVA is 6.9, these patients are going to notice enhancement. Chameen's correctly identified the normal anatomy and normal topography. So I think if you're looking at multifocals, I'd echo what Chameen said, that the IOL master is fantastic, obviously, capture time and the reliability. but the use of a pentagram or an OPD as a minimum is sensible. When not to do a multifocal, if they're not fully presbyopic, unrealistic expectations, almost the reverse. Monocularity, I think they can be problematic if the patient's only got one eye, they don't get the binocular summation. So just be very careful there. Again, testing the stereo, poor quality tear film. So spend a little bit of time. These patients require more time, and so really ask yourself, if you're willing to invest your time in it, then this is something you should pursue. The presence of macular pathology. I think in the debate it came up that these patients are getting them younger, they're going to live for longer. What happens if they develop macular degeneration? There's been quite a lot of publications that the patients actually are quite fine. They've adapted to the use of the multifocal, and if they were to develop a CRA in one eye, their satisfaction is still quite high. Other ophthalmic pathology. And the other thing is, if they come in saying, "Doc, I'm happy to wear readers afterwards," I think don't push the envelope with these patients. They're not the patient that's asking for it. And, the panel's mentioned a lot of these patients will come through the door asking for, multifocal IOLs. And I think this is going to become more and more common. I'll just go back.
See if we can get that back.
I was just going to mention a talk that study we did in our centres looking at satisfaction. And we tried to work out, whether we were achieving what we were aiming to, and we found that about over 95% of patients at 3 months were really happy with multifocal IOLs. And I know it's easy to sort of present this data and select, and we try to be very critical of, pre and post-operative satisfaction. And, as you can see, there's very much a shift towards satisfied patients with their post-operative visual acuity. Because they've got a multifocal, some of them will still wear a pair of readers, especially those that do, woodwork or really fine work. They're just using the powerful distance portion of the lens veneer. But the satisfaction rates are high with multifocals if they're selected properly. So the right patient, you're going to have to change your practice or modify it to address these patients. It's a real journey and a history with the patient. You're going to have to see them more post-operatively. And there may be some, more intense follow-up and extra time spent with those type of patients, but, it will be rewarding if that's what they've come to see you for and you're achieving those goals. So finishing up a bit early, thank you very much for listening and open to any questions. Okay.
Thank you, John. We'll get some polling questions up if we still have some time. So we've got 2 questions on multifocals. We'd like to open to the floor to see if anyone has some questions. Just direct themselves to the microphone, please. We're setting up the polling questions there.
Hey, Bernardo, can I make a comment?
Of course you can.
I just think separating patients based on if they're RLE or cataract is a little bit arbitrary, because once we've got the cataract out, they're all the same. Once you've got a capsule without a lens in it, we should be treating them all as refractive patients.
I think there's a question up there. Yep.
Thanks. Hi. Thanks for the panel. I just appreciate all your, frank experiences with the IOLs. Could I ask your experiences, the panel's experiences on segmental refractive intraocular lenses, in particular the Talion Lentis M+ MF20 IOL, and how that compares in your experience with diffractive trifocals? Thanks.
Do you want to talk about how you feel as well?
So that's my, at risk of industry being displeased, and my favorite EDOF lens at the moment. It is a really solid performer, and I think for people that are looking to get into the refractive space, it's a great one to start with. It's very user-friendly in terms of refractive miss. It's actually quite accurate in terms of its matching with its biometry, if I simplify it down to that level. We're probably coming up to 18 months of data, but the rotational stability is also quite good. The toric version has just come out in July of this year, and that's been quite an enjoyable, as in the toric version with the +3 edge. So I will quite often do a +1.5 and +3 in the non-dominant eye, but patients have been doing quite well, reaching 6.6, 6.5 in about 97% of my patients. And when we're getting into the evaluation of their near vision, I usually will tell them that most of them will get functional near up to about N8 and 10. But when we offset them, they're getting up to about N4 and 5. So that's a really nice blend, and I haven't had to exchange a single one of them. Your negative dysphotopsias are about the same rate and profile as you would with any other lens. In terms of, I've only had one patient who's noticed some glare that she takes a little bit of alpha-GAN for long country drives. But apart from that, that's about it.
Yeah, and I would echo what Tanya says. I use almost exclusively Telon for my EDOF lenses. As you say, they're a great lens to get started with. They're very forgiving, but the advantage is that you can also then upgrade your level of what you do, going to the capsular fixated version of it. So this is the Femptis, and it's exactly the same optical platform, but it's capsular fixated. And one of the things that I said in my talk, which was not lies, is that all of the new technology that allows better IOL orientation for toricity, but also centration. So you can actually choose where you place these lenses on angle kappa or angle alpha, should you choose to do so, depending on where you choose to place that rexis, and then you can have a perfectly centered lens. And in our practice, we have some data that shows that you tighten the standard deviation of the near performance significantly. So going from about an N8 with the in the bag version to N6 on average with the capsular fixated version.
To give you a different point of view, I used to do a lot of the Teleon MF30, so the higher ad. And I found that over time they'd come back in glasses. And I'd say, oh, why are you wearing glasses? And like when you do the lens, they get like amazing distance, amazing near. But I've just found that they'd come back and they say, look, that intermediate's important for them. And they end up in glasses and it kills me. So I've actually stopped using it and I've reverted to a true trifocal. So I guess the comment there is that it really depends on your experience and how you mix and match it. I prefer the trifocal over the bifocal.
We've got another question there. The final one, please.
Thanks for all the great talks. Multifocal lenses, I feel like it's really handy if you have direct access to a refractive laser for those very small, occasional post-op refractive errors. Do most of you guys there using a high percentage of multifocals have direct access to a refractive laser? And how often are you needing to do these small enhancements? That's the one thing I worry about not being a refractive surgeon, is that I may have to refer to a colleague and I'm not sure how much that's going to cost the patient.
I think as your friendly local refractive surgeon, I'm always happy to see them.
I know you treat me well, Ben, so I'm lucky there. But just in
mate
general,
traits.
that's the one thing that, you know, may make me not sleep well at night, using a multifocal and not having access to LASIK for a small, unpredictable refractive surprise.
Oh, I totally agree. And you know, for you, mates rates of twice the price. But I think that for me personally, and the rest of the panel will comment, I've got an enhancement rate of 2%. And so that's, I think, acceptable. So it's 2 out of 100 I end up taking to the laser and enhancing. Myopic errors, these trifocals are particularly prone to them. So I think it's really important when you are starting out aiming trifocals to aim slightly plus. If you do have a significant hyperopic error, laser doesn't work quite as well, so you are a little bit more stuck, and you're stuck with either a lens exchange or a sulcus add-on. But for small myopic errors, I've found transepithelial PRK is very cheap and effective, and a lot of colleagues locally will refer those ones, and we can always work something out. But yeah, I think that risk is worrying to a lot of colleagues, and so for the trifocals that are more sensitive to error, I think it is harder to get started. Whereas the EDOF lenses, you know, the Ray 1s, I was going to say Oculentus, sorry, Teleon, those lenses are a softer option, I think.
Thank you, everyone. In the interest of time, we'll close the session now. I'd like to thank all the speakers and everyone for joining us at the first Younger Fellow Symposium. Hopefully that was being very productive. I've learned a lot from all the speakers, and I thank everyone for participating. We've got quite a spread of different specialists here. Thank you.